Makerere University is one of the oldest university in East Africa. It was established in 1925 and one of its flagship faculties is the School of Medicine and School of Public Health, which has been in existence since that time, 1925. Makerere University is also one of the largest universities in East Africa. It has about 40,000 students every year it admits. And it's got a campus which is about 8 square miles in breadth. So it's a huge, very huge university offering quite a diverse number of programs. But one of its premier programs are in medicine and public health, which has made it fairly world famous.
Mm-hmm. So what are the strengths of the School of Public Health? What's famous about it?
Right. The strength of the School of Public Health is basically research, training, and in services it offers. Specifically in research, the School of Public Health has really pioneered evaluation of vaccines. The school is currently actually involved in the evaluation of HIV vaccines for prevention of acquisition of HIV. But most importantly, it has been involved in evaluation public health interventions that have a huge impact. We're involved in the vitamin A, generated the studies on vitamin A and its impact on child outcome on measles. We were very much involved in the evaluation of male circumcision in its impact on HIV, and it has generated a huge number of policy papers that are impacting on human resource in the health system. And in terms of training, it is the sole School of Public Health that is actually producing Masters of Public Health students that are principally running the health management of districts. The district, what they call the district directors of health services, they are mandated to must have a public health degree, and so we are generating that cadre of leadership to manage the health affairs of the districts, which is an administrative unit within the country. And we do provide services to a whole host of non-governmental organizations that are involved in health care delivery. And one of we are called upon to either provide monitoring and evaluation programs for their services, or strategic planning, or help them with their strategic plans, or indeed undertake evaluations of their programs whenever we do. The school enjoys a wide range of collaboration work. Both is still in service and research and training. We do run a lot of number of partnerships with other universities in the region and internationally. And this is how we come in. We do have we do host quite a number of students from North America, and Northwestern University is one of them every year, and so is Madison in this area, that actually encourages students from these universities to come and experience and work on health services in our part of the world.
How did you get connected to Northwestern University? What's the relationship like?
Well, the relationship, as often is the case, starts up with, in this case, it started up with a member of staff from Northwestern, Dr. Carrie Stewart, whom I knew as a young lady undertaking her PhD research work in Uganda. And at that time, she was undertaking ethnographic studies in the rural districts in Uganda. And when she finished and joined Northwestern University, she said, you know, she came up and said, would like to start up a program where students come and have some experiential learning in our country. And of course, I was very delighted. And we strategized on how to implement it, and we started, and we have now on the third rotation of students coming to Uganda. And one of my roles or aims of being here is to try to encourage not only the students to come, but also members of faculties to come, and also to see whether we could have collaborative research projects with this faculty. I have been very impressed and energized by Northwestern. One of the things that has impressed me is the fact that there is quite a lot of inter-faculty collaboration. The school, Kellogg School of Business, Biomedical Engineering, and International Global Health are working together to solve some problems in a very practical way that are afflicting problems in low or low-income resource setting. And I think that's very exciting for me. And I'd like to see how we could utilize these learning experiences to also have similar experiences in my university.
Great. One question that I actually have is that I understand you were one of the first people who actually did research on HIV/AIDS in Uganda. Can you tell me a little bit about how that started and where your research is now, how that has evolved?
Oh, it's a long time ago. I hope my memory still serves me well. Well, it's very interesting that when sometime around 1983, 82, we started hearing about what is now known as the AIDS epidemic in America, afflicting white male homosexuals. We were reading this in journals and following it up as a curiosity. And at that time I was a young man working in Uganda Cancer Institute. And we were interested in as far as there was a huge increase in Kaposi sarcoma in these white males. And our unit, Uganda Cancer Institute, was actually responsible for treating Kaposi sarcoma in the whole country. So we were following it from that lens. But we thought that this was a disease that was in North America among white males. And we did not think it was in our midst. So we were following it as a matter of curiosity in terms of the Kaposi sarcoma. However, in 1984, there was a surgeon called Ann Bailey working in Zambia who came and they had a conference in Kampala where I was working and said, you know, we are seeing this very aggressive Kaposi sarcoma tumor in young males in Zambia. Do you see the same thing in Uganda? I said, no, well, no, I haven't seen any of this. We still see the type of Kaposi sarcoma we normally used to see, but we shall look. Well, we did look, and we did find that actually the clinical picture of the Kaposi sarcoma that was being described in white male homosexual was actually being seen in our midst. And for a while, we had a problem to try to relate the disease in white male homosexuals to, in fact, women and men in Uganda. So the notion was, it can't be here very fast. You know, the notion was this disease is there and it has to somehow get transported this way. But the breakthrough came around 1984 when Gallo reported that he was been able to find the cause of AIDS, and there's a test that has been developed. So we quickly got hold of these tests. In fact, initially we didn't have it in Uganda, so we sent blood samples to England to test for for the particular virus, we were blown away in 1984 to get results that actually our Kaposi sarcoma patients, some of them were testing positive for the HIV virus. And when we looked very carefully, all those individuals who tested positive were coming from a particular area, Rakai district. And this led us to actually go to Rakai and investigate. Excuse me. And we actually found that indeed there was a disease that had been already described by the local population, referred to as slim disease, because of the severe wasting, and eventually these people died. That has actually afflicted the population. We took more samples of patients in the wards in the area, and eventually this culminated in our landmark paper in the Lancet of 1984 October, which basically characterized this disease, that the disease was in our midst. Still, it was very difficult to convince the Ministry of Health authorities that this disease was in our midst, because they just felt that this was a disease in North America. It has to come from North America to come to Uganda. And it took us a while to really let them know that this disease is in our midst, probably has been in our, creeping up in our midst for a long time, and that it's just, in our presence as much as it is in the U.S. Now, you must remember, 84, 85, this disease was now being characterized in North America as disease among Haitians from the Caribbean, and there was a lot of stigma around it. It had implications of diagnosis, access to care, even housing. So there was a sort of a reluctance by many governments in Africa to acknowledge the presence of this disease because of the potential implication of, as severe as travel bans for people going in those areas. And most of these countries were depending on tourism for a lot of their livelihoods. So there was a whole complex of considerations to admit the presence of this disease, which, looking backwards now, it was quite a big mistake, because that lag time to acknowledge presence, people were not informed. People went around, change of knowledge was not being passed on to the population to better protect itself. Much of the majority of people thought, this was a disease in white male homosexuals in America. And those people who died of this disease, people felt it was due to witchcraft or things like that. So but that's in a nutshell how it all started. It sort of caught us off guard, so to speak. And when we did realize, it took us a lot of time to deal with the politics and so forth to be able to acknowledge their presence. But I must say, when the new government, President Museveni's government, came into Uganda in 1986, January it quickly acknowledged the presence of AIDS. And it was like day and light in terms of spearheading knowledge, health education programs for people to really get to understand this disease, which sort of generated an environment whereby other non-government organizations could operate, and the resources that are needed to mount heavy health education programs. And we'd like to think it did pay dividends down the road with the reduction of HIV prevalence in Uganda that we have just witnessed.
Mm-hmm. What's the status of the disease now in Uganda?
Well, at this point in time, there is some indication that the disease, in terms of incidence, that is the number of new cases we see every year, is creeping up again, and so is prevalence. There are a number of factors, competing factors to explain this, but I think one of which is that we have sort of slackened in our investment in HIV prevention, education, both in terms of effort and leadership, and in terms of the resources that we are putting to bear in prevention. which in turn is really a question of, because when you look at in 1985, 86, 87, the early days of the epidemic, every dollar we spent on HIV was on prevention. However, now currently every dollar we spent on HIV, only 30 cents go on prevention. And it's a mixed blessing, because treatment became more accessible, and there is, to be sure, much more money in terms of total number of dollars available in HIV prevention and care, but a huge bulk of it is now being taken in treatment and care. It's very expensive, so we spend more money in treatment and care because the medications are expensive and people are demanding for the care. So what has happened is that the amount of money spent on prevention has somewhat dwindled as a result, and that has impacted a lot on the ability to deliver HIV prevention. And also, I think, to be fair, there has been some fatigue setting in terms of the leadership, in terms of driving up the healthcare messages as we used to have them before. So all these factors, have played together to really bring up some degree of complacency among the younger generation in terms of risk behavior. We know this from a recent national serobehavior study that was completed around 2-3 years ago, which showed that young people age 18 to 25 are having more sexual partners, unprotected sex. In other words, their risk behavior is really cropping up. I think it's too early to say that probably because of the number of people who are on treatment are living longer, therefore the prevalence is being crept up because of that. Here in Uganda, we have 1 million people who are on HIV, who are eligible for treatment, but only 100,000, 1/10 actually, are actually receiving care. So that's a very small proportion to keep preventing or elevating the prevention as a result of care. So yes, we are in a little bit of a crossroad in terms of HIV prevention, and this is more so. This is a very critical point because we get every year we are having about 30,000 new cases of HIV every year. And yet up to now, since the program started 7, 8 years ago, we have only been able to put 100,000 people on treatment. So just as obvious is that we have to bring down new incidents, new cases. Our prevention programs have to be double charged. Otherwise, we are on an unsustainable path. We have more people getting HIV than we are putting on treatment. And therefore, we can't balance. So the prevention. This is a major concern to our governments, and I think we really need to really think out of the box to drive up prevention to be able to reduce the new number of cases.
Thank you so much for sharing your knowledge with us.
Very good.
Do you have anything that you want to add, or?
Oh, I would like to say that I've been very delighted to be hosted here in Northwestern, and I have had. It has been as much a learning experience in my 2 days stay in Northwestern as it has been in terms of generating and understanding Northwestern better. And I think this has put me in a very good position to really bring up or elevate our level of collaboration to a level that I think is mutually beneficial to both university. And I look forward for a long-term relationship with Northwestern University.